Okay, well, welcome everybody. My name is Amy Vandenbroek. I'm the Executive Director of National POLST, and I'm excited about this webinar. We've had a number of questions about using the National Form. I want to first thank the John A. Hartford Foundation. They provide the funding for National POLST right now, and they make this webinar possible, so thank you to them. Some links that might be helpful for our presentation today are here. For information just about the form and where you can find links to everything else is at polst.org/national-form. If you want to see the form itself, there's the link. And if you want to see the healthcare professional guide to it, there's a link. We are working on a patient version of the guide. And then we have a lot of the patient form information on our website as well. If you are a state that is interested in using the National POLST Form, but you need to make edits, please contact me. I have a number of states that I'm working with on that right now. And then just to give everyone a sense of where we are, this is as of October 2020, and I know things have been changing, but these are the states that have adopted the form: Maine, New Hampshire, and Arizona, and those will be our presenters today. You can see that we have a fair number of states that are actively working to adopt it, either as is, or they, again, are making minor edits for it. And then we have a lot of states that are considering it, which is fantastic. And then Carissa is putting the links in the chat box, which I appreciate. Thank you, Carissa. And so finally, I want to turn it over to our presenters. This is an informal presentation. I've asked the speakers from Arizona, Maine, and New Hampshire, the states that have adopted the form, to explain how they chose to adopt it. What was their thought process? How did they go through the adoption? And for those states that have actually implemented it, how has that worked? So they will each have about 10 minutes or so to just share their thoughts on where they are. But most of this presentation is really for an opportunity for everyone who has questions about how these states did it or how they might be able to do it in their own states to ask these presenters. So we don't have very many slides, but with that, we are going to start off with Arizona. So Sandy, let me turn it over to you.
Wonderful. Thank you, Amy, and thank you for the opportunity to share our journey. I really have appreciated the support from National POLST, the guidance that has been provided, because it made this process so much easier for us to adopt the form, because all along as we developed our program, we tried to align it with National POLST. On the next slide, it tells a little bit of our history. POLST in Arizona started in 2005 with a grassroots effort just of volunteers who said, I think we really need POLST in Arizona. We had nurse practitioners and physicians and social workers and chaplains and EMS and ethicists, I think, who felt very strongly that we needed POLST, but they really had a struggle in getting it off the ground. The form was developed, I believe, in 2014, 2015. That's when I became involved with Arizona POLST. We kept getting feedback from different groups that they wanted some tweaks to the form. So in 2017, we developed a form revision task force. And the biggest feedback we got is that EMS didn't have involvement in the first iteration. And so I chaired the next, task form, this form revision task force, and we had bureau chiefs from police and fire and the guy who started the pre-hospital medical care directive 25 years ago in Arizona, and it was really kind of interesting to get their input. And you know, back then, of course, we all had face-to-face meetings. We didn't do as many webinars, and we did meet face-to-face, and we went over every single element, and we really did a thorough review, but we did look at everyone else's forms, and we pulled forms in. Arizona historically has been a very Republican state, so we had to look at Republican forms because we're not in Oregon. We're not, you know, we're pretty conservative. So we did come up with a form, and as I started talking to other POLST leaders across the nation, marketing a POLST was very difficult. And the recommendation came that, if we called it AZ most, medical orders for sustaining treatment, I think it was something like that, that it could be AZ most puts you in the control of your care. So we could use it as a marketing trigger. So we actually did change the name from POLST to AZ most. And then in June of 2018, when National POLST began working on the revisions, and Amy kept sending this out, we have a very active task force that meets on a monthly basis. And it's like we don't have a society for palliative care docs or a group. So these people don't have another place to meet other than this group. Geriatric society, certainly, but so we have very active physicians and nurses and social workers and PAs. And they really took to task the request from National POLST to be part of reviewing every single element of the National POLST Form. So every single meeting for, I don't know how long, at least a year, that's what our agendas were. I took Amy's recommendations and we put them into a PowerPoint and we discussed them. We really felt as if the national form was kind of our form now, because we had deliberated over every single element of it. Even though we didn't win all the time, we didn't get our way, we at least could understand why, and we understood the value of collaboration and the greater good. So once we realized that the nation is going towards a standardized form, a standardized process, we agreed then to change our name back to POLST, from AZ most to POLST, just to reduce variation, so that when it came time for reciprocity and ease and exchange of a registry, a national registry, that type of thing, it would be so much easier for us. So in the next slide, we really, again, I would have deadlines to get feedback to me. We would discuss things, and then there's always some folks that are working and can't make the call, and so I would give them like a week to get back to me, or 2 weeks, and it was always on a deadline because the comments kept coming and coming, and so I truly think being able to participate in the development of the national form was a turning point for us. We felt, that we had a voice, and that while it wasn't just an Arizona form, that we understood every element and why. And because Arizona does not have legislation, we didn't have to go that other route of changing legislation about POLST. So we took the decision to many, many different key stakeholders and committees. We started with our POLST task force. We also have a kind of a governing body also in our organization, and we took it there. We took it to EMS, we took it to the medical associations and the osteopathic associations. We took it to the Geriatric Society. We took it to our members, our hospitals, and the PA group reviewed it. The Geriatric Society reviewed it. And we just kind of went out as far as we could, trying to seek feedback. Was there any opposition to changing the name and changing the form? And because we could articulate the rationale that we're working towards standardization, that with standardization you reduce variation, and that if we can standardize not only the form but the education and a registry, that this is all for the greater good. there was a lot of support for that. And, you know, understanding it's a journey and we have to get there. It's not immediately. And so the consensus is that there was great value with working with National POLST and trying to be a leader, because I think we were the first state actually to adopt the form. But we felt that aligning with a national organization increased our credibility. If you know anything about Arizona, there's an anti-POLST legislation, and you know, they pretty much the group that opposed POLST back in 2014 and 2015 didn't understand it. And they really felt as if we were cowboys going out there and just developing something on our own. So we wanted to make sure we were credible, that we did align with evidence-based practice, the national organization. And then of course you always have these ones or twosies folks who reach out and you want something changed. And we felt it prudent to not be reactive to that. That if we could say, you know, if there was a real justified reason and there was consensus for the change, that we would consider that. But it helped us not have to be the mean person saying, you know, thanks, but no thanks. You know, we've decided not to make that change, and this is why. So we've just said, okay, we're adopting this form. It's not perfect, but we believe that it's good. And we're not going to let perfect get in the way of great. And National POLST is going to take our comments. So if we do have comments, that there will be a group that does review this, and we will take that forward for Arizona. And we truly feel that we are committed to aligning with evidence-based practice in Arizona. So that's our story. And with that, I don't know if Amy, you want questions at the end or now? It's up to you.
Well, are there any, I guess we can stop and see, are there questions for Arizona, or should we go on to Maine? For those on the call, any participants have questions?
Yeah. Hi, I had a question. My name is Verena and I'm from Leading Age. Hi, Amy. I was wondering how did you implement, I mean, you talked a lot about how you developed the form and then went to the national form, but how did you implement the use of the form across different settings?
Sure.
Or encourage the use? I don't know if it's called. Yeah.
Our barriers were that providers in Arizona didn't even know what POLST was, many of them. Basically, it was just the palliative care providers that, or docs that had moved into Arizona from other states. But we had a lot of lack of knowledge. So we began working, number one, we took it to the Arizona Medical Association to get endorsement and support for that, the Osteopathic Society and Association. And we just took it to different groups and we kept educating. We took it to, I believe, the Leading Age Conference probably 2 years in a row. We took it to our nursing home, our for-profit Arizona Healthcare Association. We took it to hospice, their annual conference, and the home health annual conference, the Geriatric Society annual conference, the Risk Managers annual conference. And we just hit that circuit year after year after year. The attorneys, and then we developed formal curriculum for POLST. We have an Intro to POLST class with CMEs and CEs. We have Communications in Serious Illness and POLST Train the Trainer with CMEs and CEs. You know, we really felt as if we had to provide the infrastructure for people to actually understand it and feel comfortable and safe without legislation to know how to implement that. Are we there? No, we're still implementing. So it's a journey and we're on that road.
Thank you.
Thank you. Let's continue on with Maine, and then we'll see if there's any questions after that. So Candace, can I turn it over to you and Jim?
Jim on the call, Amy?
I don't see him.
I don't either. Well, hopefully he'll join us, but I'll begin and hopefully do the topic justice. So we as well were somewhat of a grassroots effort and started in 2008, a few years after Arizona. And I guess if I was to highlight some of the major concepts that we followed throughout our process up until today and probably well into the future, the big one would be collaboration, inclusivity, diversity, thoroughness, and outreach. And that seems to have served us well. And I guess I'm going to sum up my whole brief presentation by saying two things. Right at the get-go, we realized that this was a value-added process for our organization, the POLST organization. And I mean process, I mean adopting the National Form. And the question wasn't why should we, but the real question to us was why in the world wouldn't we want to? And so that was our goal. We saw so much value in doing work with Amy. She participated in our every other month calls. And we relied on the coalition, which was composed of a very diverse group of people, to contribute, to be owners of this process. And it was a natural outcome for us to adopt the National Form because we saw no reason not to. When we started in 2008, we immediately brought in everyone from the EMS folks to the Attorney General's office, to the guardianship program, to even those who were sort of naysayers regarding the program. And you know, what is the old adage? You really have to get to know your enemies well because you'll learn a lot about them. And not that we had any enemies, but there are always people that oppose something that's new for their very good reasons. But we also felt we had the stronger argument. And so we welcomed them to the table to share their different opinions with us. And we just talked it out. One of the things we spent a lot of time doing is bringing the faith communities into this discussion. And I don't know if that's been mentioned by all of you, but it was just such a valuable piece of our process. Everyone has different opinions, but conversations, just like we advocate for a good POLST conversation, I believe in conversations for most everything. And to sit down and iron out your differences and keep in mind the common goal. So let's go back to 2008 a little bit. There were two things that were really important to us as well as the ones I have mentioned. But the other one was to give our organization a stable home and to have that home, that administrative home, be a place where there was some funding, that there was some consistency, and there was some continuity and some neutrality within the healthcare arena. So no one person wanted to own this, if you will. We wanted everybody to own it. So the coalition at the time decided that the home, because we had always been a very neutral organization and we were always a convener of various forums and bringing people together, very diverse groups of people together to talk through issues and arrive at a consensus so we could go forward together. The group decided to offer the administrative home to the Maine Hospice Council and Center for End-of-Life Care, which I have the privilege of being the director of. Jim Van Kirk, Dr. Van Kirk, who's not on the call yet, I understand, was such a champion for this cause. And that was key that is key for everybody everywhere, whether it's POLST or something else. You have to have champions within their own institutions and people that are respected, knowledgeable, articulate, who can do a lot of the outreach to disseminate, to implement, to distribute this information. So you have to find those people out there, and there are many of them, and you all know that, and probably you all are those people. So those were really some key points that I think gave us really the impetus that we needed and the stability that we needed going forward. Again, if you haven't brought your Attorney General's office into your discussion, I would really encourage you to do so. Our Attorney General at the time just wanted to make sure that people were aware this was not to replace an advance directive. It was to complement an advance directive and give it one more step forward in the form of an actionable medical order. So when it came to us becoming an endorsed state, that was a process that many of you have gone through already. But then when it came to adopting the national form, again, because our coalition was a very tight group of people, yes, are they on all calls? No, they're not. But different groups of people are on the calls at different times, but they are all well aware of what we had been doing, and they had all had the opportunity to give input into form review, our standard form review for Maine every 2 years, if they wanted to. They didn't have to, but they were invited to. So they knew they weren't left out of any piece of this process. And I think because they were so familiar with our process, and they knew they were invited to be part of any new process, to them, it just made sense because they knew Amy well too. She had been on our calls every month at first and then every other month. And I think that made a huge, huge difference because she was not an unknown entity. She was a known entity. She gave updates all the time, and they could ask her any question that they wanted to. And it made so much difference. And when it came to adopting the national form, which was very similar to our own, actually, there were not a lot of differences. It was just a natural segue. To me, it was just such an easy process. And I know every state has such different dynamics, I guess, just like families do. Politics, religious beliefs, approaches to things. And that's part of life and part of reality. But when everyone gets to know each other really well, then nobody is a stranger when it comes to taking another step in action. Again, do people have different opinions? Absolutely. But one of the things we do and always have done is welcome those differing opinions and just make sure that people disagree without being disagreeable. So I think because that's been a part of our sort of process and mantra all along, it was an easy thing for us to segue right into. And people were really happy about it because they had such respect for the national office and the work that was done and why it was done. So I just can't say enough about everyone, actually our coalition members and the folks that work at the national office. So thank you, but it's just it was such an easy process for us. Yeah.
Thank you, Candace. That was really great to hear. Are there any quick questions from Maine before we go to New Hampshire and then open it up?
Yeah, my name's Ellen Dang. I'm a nurse practitioner in New Hampshire, and I tend to go into Maine sometimes. And in Maine, the POLST and the Dnr forms are combined.
Mm-hmm.
And I wonder if patients who live in Maine, if they go to hospitals in New Hampshire, because are those forms valid?
Well, the POLST form, I'd just like to go back and revisit part of your question, make sure I'm hearing you right. You said the POLST forms and the DNR are combined.
Right,
Yes,
they're on one sheet.
That's right. DNR is included with the POLST form. You're absolutely right. But one of the things we stress is it's not to replace a DNR order in a facility, which is actually page 14 of our advanced directive form. So that was a conversation we had to have right at the get-go with a lot of people. There were a few things that came up, and I'm sure many of you ran into these in your own state, but people said, well, why have two forms? That's too cumbersome and it takes too much time and I don't have the time to do that. And so we're just going to have the POLST form replace the advanced directive form. And so I made many a trip to many an institution and just sat down and had a very reasonable discussion with folks, no matter whether they were strongly opposed to the fact that two forms were appropriate and this is why. It was worth the conversations because what it did was solidify the trust they had in our work and the reasonableness of our explanations and conversations. So at page 14 of our advanced directive in Maine is really the DNR form. And if you remember what I said a few minutes ago, our Attorney General said flat out right at the get-go, you will not infer that the POLST form is going to take the place of an advanced directive. So that is important for me to share with all of you. Yep.
And then Brian, I see that your hand is raised. And so being from New Hampshire, I didn't know if you had a response as well.
I did. Hello, Ellen.
Hi.
I believe your question, part of your question was, would New Hampshire automatically honor an out-of-state POLST form?
Correct.
And my answer to you is, yeah, no, maybe, kind of no. And I think I can do a little better than that, so let me have a go at it. Technically, our POLST form can contain a DNR order. There is an actual law in New Hampshire that defines DNR orders that are portable, that is, that can travel from institution to institution or be honored if you're in the field, you know, if you're living at home, that kind of thing.
Right.
And that requires the authorization of a provider who is licensed in New Hampshire. So technically, my doctor in Maine can't authorize you in New Hampshire to operate on the basis of his or her orders for a DNR. That's the no part of all my stammering answer.
Okay.
The yes part is obviously any good practitioner or clinician, and that's the only kind that we have in New Hampshire, as you know, would do whatever they could to discern a patient's intent and wishes and would try to honor it on that basis. Okay. But it really does underline the reason that we're all having a discussion about a universal national form, okay, one that is automatically recognized here, there, or elsewhere.
Thank you.
All right. Well, Brian, let's stick with you and have you present New Hampshire. And then again, we'll open up for more questions.
Thanks. Good afternoon, everyone. So I work for an organization called Foundation for Healthy Communities. Now, that's a nonprofit partner to the New Hampshire Hospital Association. And we are sort of the home base or the responsible entity for things related to POLST and advanced care planning in the state of New Hampshire. And that's because the state of New Hampshire, in its various departments and divisions, has really had no interest in taking responsibility for that. But of course, everyone would like to see it get done. So for many years, and I want to say something like 30 years, we've had a coalition. And the coalition started around advanced care planning and has sustained, and I'm on that coalition, and we're the I chair that coalition, and my organization is the seat of its meetings. So we got into, let me stop for a second and thank Sandy and thank Candace for their presentations, because a lot of what you reported relates exactly to where we are in New Hampshire. So I will probably refer back to that, but thank you for your presentations. We got into the business of POLST probably a little later than Maine did. And POLST does not exist in New Hampshire law. Okay, that doesn't mean it's illegal. It just means that there's no statute that says what it is and what it ain't. When it comes to adopting forms, that's good, because you don't have to get a whole legislative body or two of them and a whole bunch of other people to agree and sign off on it. So we have crafted the New Hampshire state form to include the requirements that pertain to the DNR form, because POLST, as you know, can contain a DNR order. We want it to be effective. We want it to be portable. We want it to be recognized. But New Hampshire is a small state. Paul might add we're a small but a mighty state. Nonetheless, we're small and we're bordered by Canada, Vermont, Massachusetts, and the ocean. The ocean doesn't care, but a lot of our patients, particularly in the well-populated southern and eastern part of New Hampshire, get tertiary care in Boston, in the major medical centers there. Our only university medical school teaching hospital is on the Vermont border in the western part of the state, which means that we have a lot of people crossing boundaries and rivers back and forth, and reciprocity is really, really important. It makes for miserable continuity of care if what is normal and routine for people in sharing providers between states is clunky in the way it works. So we were very interested in helping to develop a national form. And this relates to the Arizona experience. All of our coalition got very involved in responding to every iteration in every draft. Amy may remember that. Maybe it may have become tiresome. I don't know, Amy, but on our end, it meant that there was an immense buy-in already to the national form. Okay, our emergency response community was very active. Our medical people were very active. Our hospital people were very active. And many of our legal community, the attorneys who work in this realm, and particularly with elder care and that sorts of things, our hospice community, all very, very active in seeing the national form develop. And like Arizona, we had our say, and sometimes our say carried, sometimes it didn't, but we did buy in. Now that it was announced that it's been finalized, we at our coalition meeting, we said, so now what? What do you want to do? And we all said, well, gee, hell, I mean, this will work, All right, let's think about it and come back to it. And every couple of months when we met, we think about it, come back to it. And then last June, we said, why don't we just do it? And so we made a decision to just do it. Now, I know that's simplistic, but that's really how it came about, the decision to adopt the form. But we haven't done anything since then to roll it out. We're still using the forms that we've been using in New Hampshire and revised in 2017. Actually, the same people who did the revision of that form at great effort became quickly involved in having an interest in the development of the national form. So it's been a pretty organic process for us. What we're waiting for is that we have this summer begun to submit some legislation which is being introduced in our legislature this season, which runs essentially now through April. Okay, and we want to update the statutes that govern our advanced care plans, our advanced directives, our medical surrogacy, and do not resuscitate orders that are portable. That statute over the years, there were things that were compromises in the first place. There are things where the world around it has changed. There are pieces of language that are archaic and confusing. And we were waiting for an opportunity. We don't want to go to the legislature every year because A, it's exhausting, B, it will annoy them, and C, they might get ideas of their own. And our legislature is like 500 people. And that's a lot of possible ideas. So we want to just kind of be tactical about how we do that. And so we kind of worked up to this, thought this would be a good time. And POLST is now going to be, if this is adopted, POLST is now going to have a place in New Hampshire statute. What we want to do is basically say that POLST is an acceptable iteration of a portable DNR order. It is more than that. Everyone on this call knows that. But for the purposes of reference to the existing law, we want to make sure that it's understood. And we also want to change that little piece that I mentioned to you about who can write a DNR order and or a POLST, okay? We want to make sure that any POLST written in any state, or for that matter, any DNR order written in any state, is actionable and honorable here. Our EMS community is on board with this. They bought in. They very much want to make sure that every patient gets their wishes honored in the field. And they've pushed us to keep things very clear and very simple. They don't want their people fumbling through papers at a crisis in the field. But that said, their protocols allow for POLST to be recognized. And so we think that we can improve all of that, but we don't want to roll out a new form when we're not sure what the outcome of these pieces of legislation are. So we're probably going to delay our reprinting the forms. That's the bad news, because we made a decision and you say to us, well, how did you do it? We really haven't done much. You know, I'm a little embarrassed to say it, but for good reason. We think that it will give us the opportunity to do a fairly assertive campaign of explaining what the changes in the statute are and what POLST is, okay, and why there's a universal form for POLST. So that's kind of where we are right now, and I'd be happy to take any comments or questions that you have.
Well, thank you, Brian. I appreciate that. And it's still a step forward to say that you're using it, and I appreciate the thoughtful rollout. So it's still a good story to share.
Okay.
With that, are there questions for our presenters? Or I apologize, and I'm fighting a sinus infection, so my mind is a little fuzzy. I didn't really go into the history of the national form. If you have questions about that, I'm happy to take them. But otherwise, the focus was really about how did states decide and how are they implementing? So are there questions that people can answer?
This is Ellen from Honoring Choices in Massachusetts. Hi, everybody. Brian, I just wanted to ask you, although I mean, you don't look fuzzy, Amy. You look on top of it like you usually do. Brian, just you know, we're starting a process here, and since we're right across the border from you, we'd love to do this with you in many ways. So as you start to move forward, I think it just would help all of us to be able to communicate with you. So I hope to do that with you. But do you have a sense of, you know, your next steps in moving things forward?
Sure. When we can predict the likely outcome of the legislation, and that may be some weeks before somebody signs the final law, but you know, when all the ducks are in a row,
Right.
Or when all the ducks have gone flying in a different direction, at least we know what direction it's in, okay? We can begin to do some of the things that are obvious. Number one, we need to inform everyone who we know is currently using POLST in New Hampshire that there is a national form. And from now on, and we will pick some day, you know, we will know, by the way, the foundation I work for is the one that publishes these forms for people and distributes them. From now on, you'll be getting the national form. It may say New Hampshire's version of the national form. We have to figure that out, but it'll say, then it'll be the national form. You'll be getting that, and this is why, okay? I want to, the reason for delay is obviously to couple the ground rule changes, if there are any, with that rollout, because we have a list of everyone we've ever given a form to, okay? We have a list of everyone that we have ever trained in POLST facilitator discussions. We have the organizations that are part of our coalition are themselves, many of them are fairly powerful organizations, such as the Home Health and Hospice Association. They have an immense list of POLST users and people who should be using POLST. Again, POLST is not that ancient an artifact in New Hampshire. It's still, there are still some places that don't use it. Okay, and this is a way, again, like the Hospital Association that I'm connected to. These are ways that we can call attention to this tool. And so those are some of the things that we'll actually be doing. I'm guessing, Ellen, that we'll be doing this around, around the first quarter of the next year. Okay, that's when, but I don't know. And politics confuse me. So we'll see what happens.
Yeah, and the pandemic's not going to help. So, yeah.
That's right. It all could, because of that, it all could be tabled. Our legislature's meeting in a hockey rink someplace, and they may decide we can only do 4 things, I don't know.
Thank you, Brian. And just a follow-up question, if I may, Amy, for all the 3 presenters, did anybody in a rollout do a pilot? Did you take a section of the state or different communities and roll it out there first?
That's a great question. I'll make sure that we don't talk over each other. Sandy, how about you speak for Arizona first?
We didn't do a pilot with the new form, but we did a pilot with our original form. We had a small 2 hospital system that piloted POLST initially, and then did publish on their use of it. But with the revisions, we felt, no, there just wasn't, we didn't see a need for a pilot. We felt that it was all or none. We were going for it.
Right, and Candace or Jim, welcome. How did Maine do a pilot?
Same thing in Maine. We just rolled it out. It was so close to what we were already using, and we just put it out as our newest iteration. We have a every 2-year version anyway, and so it was pretty easy to just flip over.
And Jim, Amy, can I jump in here?
Yep.
Jim, don't you think it was because our process was so organic and that we're so many people that were included in every step of the way that it was kind of an easy do?
Yeah, it was very easy to.
Yeah.
No challenges at all.
Right.
It's a small population state, so I think that always makes it easier to accomplish things. But
That's, yeah, right. Yep.
And Brian, New Hampshire, are you planning on doing a pilot?
I would say no. It'd be a little bit like herding squirrels to get some people to only do it and some people not to do it. So again, the comments from our neighbors in Maine were about the same size in terms of population. It doesn't make sense to hold back a part of it. It would be hard to sequence that. So.
And I'll say that in coming up with the final version of the National POLST Form, those of you that were involved probably remember some options that looked really different than what most POLST forms look like. And part of that was trying to think outside of the box. If we were to start over again, what really is the purpose of POLST, and can we accomplish more of what we're trying to do in restructuring the form? And that was probably my favorite part of the whole process, because those different looking versions of it got the most reactions. Like, I was getting immediate emails back of saying, no, never, like, don't even think about it. And then a couple of weeks later, I would get an email from the exact same person being like, I haven't been able to get that out of my mind. I think that's an interesting idea, but we can't roll it out. Like, it's just way too different. And you would be, it would be dead on arrival, because no state would be able to easily transition from what they have where they're going. And part of that is because we've done a really great job with our endorsement standards and having endorsed states, and even a lot of our active states have been doing this for a long time. Their forms look very similar. And if our goal is to build consistency, and that is our goal, is to build consistency to make this easy for patients to use across states, for everyone to really understand what POLST is and to be able to do quality assurance, it made sense to say that that was an interesting idea to talk about different ways of doing it, but let's focus on what can be easily adopted and that we can build uniformity over, and then talk about what in the future we might want to change. So a big part of this was trying to make it easy and not a huge leap for people to adopt it, and not have anything that was so striking that it would be a barrier. Are there other questions?
Yeah, hi. I had another question. So in the states that, like in Arizona, where it's being used now, the form, do you have any sense of how widespread the use is, and if it's used if the form is used correctly? And also, are there what are do you know of any challenges that providers in different settings have in using the form? So it's 3 questions.
You know, we do know that it is being used, especially with COVID, because we've gotten quite a few calls, especially for ER docs or docs in the ICU with the large health systems. We, at the beginning of the COVID spike, our intro to POLST classes went from about 25 to 30 to about 160 in the class. We just held a monthly class. And then as you start getting calls from these docs, they say, I attended your class and I'm using this form and I have questions about this and this, and you know, and what we did to simplify POLST use is that we created a very simplified advanced directive form that was 1-page advanced directive and 1-page a living will, and a 1-page healthcare power of attorney with mental health authority. And we put a little box on there to say, check that the POLST is attached, if you've also completed that. Because we want to make sure that all forms actually align. And that was the feedback that we got from our providers is, you know, they already have an advanced directives, but it's really old. I heard you have this 1-page form. Where can I find it? And then we worked with the Prepare for Your Care folks, and we actually customized, and it was well worth the $5,000 a year, because we customized our form to add a page about POLST. That's large print and 4th grade reading level. And that's being used, you know, and so it's those kinds of questions that we get. That it's really interesting. I was on a call yesterday with a group of docs from a rural hospital and then a very large hospital in their clinics, and we talked at length about their POLST implementation, and they've gotten a grant and they're designing the EMR with the goals of care and that type of thing. And so we really, you know, you're trying to problem solve with them on how to do it. You know, but you know, every organization is different. You can provide input, but you can't do it for them. So we know that it's being used because we see that we're not like New Jersey. We don't have an organization who prints them off and sends them out. It is just, you print it off yourself. The providers print it off themselves, and they do that because I get calls and ask, you know, does it have to be on newspaper? Does it, you know? So I know that it's being used. I know that it's being used in different hospices and home health agencies. Also, did I answer all 3 questions? I'm sorry, I don't remember.
Andy, this is Vicki, and I think the other question was about how do we know, do we have a quality assurance mechanism? And I would just add that in Arizona, we have a very robust health information exchange. And they are going to be the repository as our advanced directive registry come early 2021. And so we will build in some QA mechanisms in that as we're implementing our new registry.
Thank you. Candace, did you have something you want to add there? And then Paul?
Yeah, I did, Amy, thank you. I'd just like to respond to two things. One is that we have one of our metrics is we have a permission to print form that folks, it takes 2 seconds to do it. They fax it to us, a provider I'm talking about now, and they can't copy it themselves till they register with us and get the electronic copy. And then they can either print the forms themselves, or if that doesn't work for them and they want us to do it for them, we do that, and we will ship them out to them. So that is one way we can keep track of who's utilizing the POLST forms and get a sense of the penetration in the state. And then that gives us an eye to what rural areas of our state really need more attention. So I find that metric probably one of the most valuable metrics a starting organization or a fledgling organization can use as a way of keeping track of the utilization. The other thing I wanted to mention, and Jim, jump in here with anything, is that our office here spends a lot of time fielding consumer calls. Consumers have heard about the POLST form and they think it's synonymous with advanced directive, or they just flat out don't understand what the difference is between the two. And I really enjoy fielding those calls, and I have folks tell me their story, and it gives me a whole lot of time to do education on the phone and help people understand the difference between advanced directives, what a POLST is and how it augments an advanced directive, and actually how to connect the two. And I was driving along one day and all of a sudden I thought, there's so much confusion on the part of consumers. Why don't we suggest that they, and you may do this, you folks may do this already, so bear with me. Why don't we just suggest that they put in their narrative and their advanced directive, in the event that I am diagnosed with a terminal illness or find myself in a state of advanced medical frailty, I wish my primary physician to have a conversation with myself and my family about a POLST form. And that connects the two, because consumers, many of them are confused with healthcare on a good day. And if we can do anything, even something small like that, to help people understand the connection, I'm a firm believer in connecting dots in healthcare. And so this is one way we can do that. And I would suggest all of you, if you don't do something like that, to help people make that transition and understand the why of it, to do something simple like that.
Candace,
Thank
this
you,
is
Candace.
Sandy Severson.
Sorry,
Can
real
I
quick,
ask a
Sandy.
question?
Paul had something to add too. I wanted to make sure we heard from him. Sorry.
Just two things. Number one, Candace, that last comment that you made about speak to my physician about having a pulse is a great idea. What I wanted to ask Sandy was, does the fact that, in a sense, page 3, where you say attach a POLST form here behind the advanced directive or durable power of attorney, does that create confusion as to the difference between what people understand an advanced directive is, as opposed to a living will, as opposed to a POLST order? Because the advanced directive itself is something that's completely different from the POLST order itself. And one concern that I would have, and this is just my own observation, and I'm going to steal a quote from a colleague of ours, and that is that it almost seems as though it's trying to make an advanced directive on steroids. And that's not what my understanding of what a POLST is supposed to be, that they really are two very different documents and do two very different things.
No, we totally agree with you. They are very different documents. Our real challenges are laws in Arizona that, because we don't have legislation, we actually have anti-POLST legislation. And bottom line is that we really need to make sure that all documents align. And that's what that's about, is that if a provider is completing, certainly we worked with the Attorney General's office, but if the provider is completing a POLST form, we want them to do a update for the advanced directive at the same time to make sure all documents are in alignment, unless they have that document, which many times they do not. So it's just, that is for their ease. We have had no feedback that it is confusing. We're very clear in we do a lot of community outreach and education on what is, a living will, what's a healthcare power of attorney, what's a POLST form, what's the pre-hospital medical care directive. We really haven't had confusion there.
And I did post the webinar that Sandy and Vicki had done last month regarding Arizona's approach to this in the chat, and that was also featured on our newsletter that came out today. So if you haven't seen the newsletter, I will put how to subscribe in the chat as well. We've got about 3 minutes left. Is there a final question for these presenters about adopting or implementing the national form?
I have a quick question for Candace. The request to print, we did talk about doing something like that in Arizona, but our concern was that we get these, we're not available 24/7. And so, and they need it timely. They need it when the patient's in the office. They need it, in the ER, in the ICU. And we were afraid that that would be a bottleneck. Have you found that to be the case?
Well, I'd like to have Jim weigh in on this too, but I have had no one in the years that we've done this say that this is not working, that they need it when they need it. Because what I usually do, if somebody calls me on the phone and says, I need it now, I'll say, what institution, what organization are you with? And I'll give you a name and your contact information. I'll send it right out to you. So, I'll save them a few seconds because they need it now. So it's not that I never, or my executive assistant never sends it. She's not as available as I am. So I know what it means to be in a dire situation, and when you need it, you need it. And I'd like to have Jim weigh in on this too. But we have not run into that, Sandy, fortunately. Yep.
We don't have to contact the council every time we print the form. So when the new iteration comes out, my palliative care group immediately send in to be approved or certified to print the form. And then we had the form, and then we could go ahead and print them. And we keep record of how many we've completed to feedback that information to the council. But it's not every individual time. It's to make sure that the people that have access to it have gone through the education and the training and know what they're doing with it. And quickly, the other thing I'd add to the last question, we have trouble in Maine where we have pockets of palliative care that are exceptional and are using POLST a lot. We have a lot of rural areas that are spread out and very poor access to care for a lot of those people. And POLST is not being used a lot. And we're about to launch a trial with Amy, trying to look at educating and seeing what we can do to do a better job reaching the more rural areas. And the last thing I'd say is that our state advanced directive form, it's not legislated. The Maine Hospital Association puts out an advanced directive form that everybody uses. And it has a one-page do not resuscitate order tacked onto the end, which we go around and rip off as much as we can, because when we hand that to patients, and every patient that gets admitted to a hospital in Maine gets one of these, they go through the 14 pages and they see a do not resuscitate at the end of this advanced directive, and they immediately think the whole thing is about withholding care. And so I think it is important to keep POLST and do not resuscitate orders and things like that separated from the advanced directives. We do encourage, as Candace said, that we reference, that patients reference them in their advanced directive. But I think keeping the forms apart is very important. One is a form that a patient completes. One is an order that is done by a health professional. And I think that it's too confusing to people when they get it all together in one packet. And I'll shut up. Thank you.
Well, we are at time, so I wanted to thank everybody for presenting. If people want to stay on and continue the conversation, I'm happy to do that. We have this line still open. Otherwise, hopefully this was helpful. It will be posted online and it will be in our next newsletter, highlighted as a link.
Thank you, Amy.